I am.
Good afternoon. It's Elizabeth Hardig with the American Planning Association and the Plan4Health project. It is just about 12 o'clock, which means it's time for our peer call to get started. I see a couple of folks are just entering the webinar room, so maybe I'll go over housekeeping items before we dive into our conversation this afternoon. We do have the chat box. You're welcome to send questions to Betsy, our presenter, throughout the call, or it's a small enough group where you're welcome to just unmute your line and ask us a question directly. That would be more than okay. We are recording the peer call this afternoon, and we will post the session on the Plan4Health website. And I think most of you are pretty familiar with our website by now, but just in case, let me go ahead and add it to the chat box right now. So we have our upcoming events on the website as well as an archived events page. And of course, many resources and toolkits from Plan4Health coalitions as well as our partners from across the country. So our theme this week in Plan4Health land as well as part of the Partnering for Health project is really active transportation and thinking about biking and walking. And I know yesterday Mark Fenton presented a wonderful webinar about active transportation investments, and we wanted to kind of continue that momentum, continue the theme with our Health by Design coalition from Plan4Health Cohort 1. So Betsy Prentice is with us this afternoon to talk a little bit more about the project that the coalition completed during the Plan4Health period, and really to share more about Health by Design and the Indy Walkways Master Pedestrian Plan. So we're so happy that Betsy's here, and I'll go ahead and hand it over to you, Betsy.
Okay, thank you, Elizabeth. Hello, everyone. I just want to say thank you to Elizabeth for allowing us to share some of our work here in Indianapolis. Again, my name is Betsy Prentice, and I am contracted with Health by Design. Specifically, I work on some of our pedestrian projects. Kim Irwin, I'm not sure if she's on the line yet, but she will be joining us, is our executive director. And she is the mastermind behind our Plan4Health project. So Kim, feel free to jump in and add to the conversation wherever you see fit. As Elizabeth mentioned, we were a part of the first cohort with Plan4Health. So we are now on the other end of things, and we've been in your shoes, and we're excited to hear and learn more about your projects. I'm sure you are all in the midst of some fantastic work. So before we get started, I do just want to briefly mention who Health by Design is. I won't do this with every slide, but I do want to just read this slide. Health by Design is a coalition of diverse partners working to ensure that Indianapolis and communities throughout the state have neighborhoods, public spaces, and transportation infrastructure that promote physical activity and healthy living. So this next slide is really great. I love this graphic because I think it does a great job of providing a visual of who Health by Design is. And essentially, we are the intersection between public health and transportation and land use in Indiana. We consist of several work groups, which I will not go into just for the sake of time, but if you are interested in learning more, our webpage is www.healthbydesignonline.org. So our Plan4Health project components, and the way that we pieced all those components together was under this brand, Walkways, moving Indy forward. Kind of high level, Walkways is an initiative to make Indianapolis more walkable and to get more people walking. I do want to draw your attention to our webpage, the Walkways webpage. It's www.indywalkways.org, and I see Elizabeth has also added that to the chat box too if you're interested in visiting our website. So Health by Design, we partnered with the City of Indianapolis and the Marion County Public Health Department to launch this initiative. As I said before, there are several pieces to our project. One of those pieces is a comprehensive pedestrian program. I'm not going to talk a lot about that today, but if you have further questions, we'd be happy to answer those. Also, the development and adoption of a pedestrian master plan. In Indianapolis, we had never formally adopted a pedestrian plan, so we're really proud of that. We also had a community-wide promotional campaign, which I'm going to talk a little bit about. And finally, analysis of pedestrian crashes and designation of pedestrian safety zones. I do want to mention that this piece of Walkways was actually another project. It was funded by another grant, but there was a lot of overlap, and it fit nicely into our Walkways work, so we thought it was worth mentioning here. I do want to acknowledge that we worked with Nelson Nygaard Consulting Associates. They were instrumental in helping us create and develop our pedestrian plan, and so we always like to give them credit when we can. As far as the actual plan itself, there were several pieces within the plan, things like vision and goals. We looked at the current state of walkability in Indianapolis, but really what I want to hone in on today is how we set priorities for pedestrian projects in Indianapolis, and I mean that in terms of geographical space. How did we set priorities? And then within that space, how did we choose projects? Before I do that, though, I do want to just mention the purpose of it was to create long-term vision for a more walkable and a more healthy Indianapolis, to establish clear, equitable, data-driven priorities for future investments, and to recognize resource constraints and make the most impact with available funding. So that last bullet point brings us to the next point of selecting priority areas. Indianapolis is not unlike other cities and towns across the U.S. in that we have limited funding, limited resources. So we, of course, could not fund every pedestrian project that comes to the table. So we wanted to come up with a way to select areas around the city that pedestrian projects would have the most significant impact. So just a little bit of background on Indianapolis. It's relatively large in size. It's almost 400 square miles. There's both urban and suburban areas, and we do have small pockets of farmland, although not a lot. So when we have all of this land space, how do we choose what areas to prioritize? Well, we did so by looking at the city through several lenses. One of those lenses was health. So we looked at where our overweight and obese population was, where those with diabetes, access to groceries, access to parks and greenways, and collision density. I do want to mention that on our website, we have the actual the master pedestrian plan. So if you have further questions about how we got the data and how that process looked, you're welcome to visit that and open our pedestrian plan for that information. Another lens that we considered was equity. So this is where we were looking at where we see poverty, seniors, youth, no vehicle households, limited English, and those with disabilities. Another lens that we considered was high pedestrian collision corridors. So as I mentioned earlier, as part of the Walkway strategies, we analyzed pedestrian crashes to see where in the city we were seeing the most pedestrians being struck by cars, or where the rate of pedestrians involved in crashes was the highest. And so we did this with the help of an epidemiologist who used local police data and EMS data. And from that data, she was able to identify zones in the city that we wanted to look at a little bit more detail. We wanted to see what was going on in those specific zones where we were seeing being struck. So in conjunction with the information that she gave to us, we conducted several walk audits, and in fact we are still, this is ongoing. We have not completed all of our walk audits, but we are currently doing so. And really with these walk audits, we just wanted to get a clearer picture of what was going on in the area. So we wanted to see infrastructure. Are there sidewalks? Are there marked crosswalks? Are there pedestrian signals? We also wanted to see who was walking in the area. So our goal is to implement some countermeasures here in the near future, and we want to make sure that we target the right audience. So we were looking at, again, who was walking in these areas. We wanted to see if there was anything unique with driver behavior. So this picture that you're looking at is one of our walk audits, and we invite the community in these zones to join us. As you can see here, we have some police officers, we have some members of the local health department, we had a gentleman from a local high school and from a university, and it's really nice to have the community involved because they are the ones who live and work and play in these spaces, and they have a unique perspective as far as what's going on in these areas, and they are engaged and they're excited about our work, and so we have been really encouraged with the participation that we've had from the community. So another lens that we looked at was walking comfort. Here's where we consider traffic volume and speed, travel lanes, are there sidewalks, is there street lighting. We also looked at pedestrian generation, so population employment, transit, so things like proximity to parks. And finally, we considered city priorities, so TOD station areas, reconnecting our waterways, high crime investment areas, and catalytic neighborhoods. And what I mean by that is the city has identified neighborhoods and said, okay, if we provide them some resources and really invest in these neighborhoods, we think that they can really flourish. So after we gathered data on all of these lenses, we gathered as a project management team. So this group consisted of people from our consulting firm, of course, staff at Health by Design, both state and local health departments, the city of Indianapolis, and several other groups that have an interest in this work. And we came together and said, okay, all of these lenses are important to look at. However, we think some things should be weighed a little more heavily than others. So as a group, we decided that health, safety, and equity would get a little bit higher score than some of the other lenses. So we didn't discount comfort, demand, and city priorities, but as you can see, the health, safety, and equity got the highest score of 3. So our consultants took this data, took this information, and took the scores, and they compiled it all to give us our high priority area graph. So we have 3 tiers. The dark blue or the dark navy blue is tier 1. This is our highest priority area. Tier 2 is a little bit lighter, and tier 3 is the lightest. As you can see, tier 1 doesn't make up a lot of geographical space, but within that tier 1, there are almost 2,000 pedestrian projects. So even though it's a small, I don't want to say it's small, but it's a smaller amount of space, there are still plenty of projects that have the potential to be done in this area. So once we had the map, we wanted to get some community feedback. So we had 5 pedestrian open houses, 1 on each side of town, the north, south, east, west, and 1 downtown, where we showed the map to the community, and we said, okay, we explained the process, and we asked, do you agree, do you not agree, what are your concerns, and we had a really great turnout at all of these events. So we were really happy with the amount of people that came out. We also had some interactive activities. We wanted to know what destinations were important for community members. So is it important for you to be able to walk to school? Is it important for you to be able to walk to a hospital or to a grocery store? And we collected all that information from these open houses to consider for our final plan. So, in a couple slides back, the high priority areas are geographical spaces, but within those spaces, again, there were almost 2,000 projects, and so we needed to narrow down those projects to select which ones we think are the highest priority. And so I'm actually going to refer to Kim for the next couple of slides to explain a little bit more about how that process works.
Hi everyone, this is Kim Irwin. I'm the Director of Health by Design. Thanks for having us on the call and for joining us. So Betsy's done an awesome job of telling you or giving you an overview of the project. And as she said, and Elizabeth, I don't know if it's possible to go back a few slides to the geographic, the map with the 3 tiers, but thank you, there you go. It's, again, Betsy laid it out exactly. Essentially, there were 2 phases to the prioritization process to help us understand overall where we should be making investments. And this geographic prioritization was the first piece, and it relied on all of that data that was shared, and again, helped us understand geographically the areas of the city where we would expect walking demand and where there's need for walking infrastructure. And so essentially, this is a guide to prioritizing investment. Just to say quickly, what this map doesn't do is reflect existing infrastructure. So you'll see essentially downtown Indianapolis is right in the middle, kind of where the word Indianapolis is. And there's actually, of course, there's always room for improvement, but very good infrastructure existing there. The point is the map is showing that's where you would expect need, where we need to ensure that we maintain good infrastructure that supports walking and other programmatic aspects. And so that, again, I just wanted to point that out, that it doesn't necessarily reflect the presence or absence or condition of existing infrastructure, but instead where that need is. So, as Betsy said, within that highest priority geography, though, there are still several thousand projects. And so part of it, the next step is to figure out when we're then prioritizing, again, very limited, how do we pick one project versus another, especially because there are different project types, right? You might have crossing projects versus linear corridor-based projects. You might want to invest more in placemaking or even more programmatic aspects around safety. So when you're choosing the types of projects in which to invest, how do you do that, even within the same geographic prioritization? And so what we did was have a second screening process, essentially, that looked again at important factors, or the factors we determined to be important in deciding. And you'll see there's some overlap with the data that was used above as well. But essentially, that idea of improving access, both to transit as well as to nearby destinations, was very important. Obviously, people need to be able to get to places, and they need to be able to get to transit. And so that specific example, or that specific factor, again, rises to the top. We also wanted to continue to support or to prioritize supporting active living and healthy communities. And so the Enabling Active Living talks about things like connections to park or connections to healthy food, like farmers markets, grocery stores, that kind of thing. And so that's the active living component. The land use typology, again, sort of ensures that we're not prioritizing certain community contexts instead of others, and so takes into account, again, what the surrounding uses are in that context. The barriers or gaps, looks at key issues. So there are rivers and creeks, and so if, people need to be able to get across those. Major corridors or interstates that, essentially become barriers oftentimes for walking. We wanted to account for that. And then the potential to leverage other funding and the favorable considerations are much more qualitative, if you will, or subjective, but essentially that allows us or builds in some flexibility in thinking about, again, where other money comes into play. So if the state comes in and says, hey, we're going to do this project, that may bump or provide a bump to a project that would be lower on the list, but because it can be done at that time using other money, then we would want to be able to account for that. And then the favorable considerations accounts for things like neighborhood support, other investment, and again, things that you can't sort of determine via GIS, but that we all know play a role in determining what gets done. So then on the next slide, essentially what we did is rank those thousands of projects using that secondary lens, and came up with a list, and we ended up, what we're showing you here is just the top 100 projects throughout the city, again, literally out of 3,000 plus. And so anyway, we can talk more about them as needed, but that's what brings us ultimately to saying, okay, this project, say the one in east-west corridor, you can see several like pinkish dots toward the west end, that's 38th Street, and those are transit stops and intersections where we know there's high crash rates and lots of destinations, lots of people using it. So we can say, that corridor, those intersections rise to the top when you look at all of the projects throughout the city. I'll pause there, turn it back to Betsy, and we'll finish up.
Okay, thank you, Kim. So that was an overview of how we prioritize pedestrian projects, but as I mentioned, there were some other components to the Walkways project. This is, again, our webpage. This is what it looks like, and we encourage you all to go visit and ask questions. As far as public engagement opportunities, as I mentioned earlier, there were 5 pedestrian plan open houses. We also kicked off Walkways with a cinema and pedestrian plan open house. And then we also distributed 2 surveys. We did this via social media and through our partners. And we got some great responses on those surveys, which if you have questions about, we can talk about towards the end here. The promotional campaign piece, we are getting ready to hit the ground running with this. So the purpose was to create community. We talked about going guerrilla, reaching Indianapolis people in their car, media relations, paid media. We wanted to make it fun and competitive and to be the authority. We are, again, like I said, getting ready to launch a campaign. We're really excited about. We should be doing that here in the next couple months to kind of reinforce some of the things that we had talked about in our pedestrian plan. So on our webpage, we also have an event calendar. We invite the community to participate in free public walks. We have several organizations that are very kind in that they allow us to promote their walks, and we have many partners who do this on a weekly basis. So the YMCA has a walk every week. Walk Urban Indy, which is a local organization here, does a walk every week. And so anytime we hear about a free public walk, we ask permission to put that on our website. And these are just some pictures from our some of those walks. This was a rainy day, but we still had a good turnout. And let me go back here. This was on our canal. If you've been to Indianapolis, you might be familiar with our canal that runs downtown. That was a walk along the canal. And then these are some more of our walks. The picture to the left with the city in the background, that's on the Cultural Trail in Indianapolis, which is a popular destination for tourists. So as far as lessons learned, our successes are that we really strengthened partner relationships. We established some legitimate makers. We had our plan adopted, so we institutionalized some processes and practices, transparency and benchmarking. Some challenges were, of course, timing, change in administration. There was an election right in the middle of our project, capacity of partners, and limitations of data, which is probably pretty much across the board. When you have a project like this, you experience some of these challenges. So thank you so much for allowing us to share, and if you have any questions, we would be happy to answer those.
Great. Thank you, Betsy and Kim. That was wonderful. I know I've looked at those maps a million times, but I have to say, whenever we get to the blue map with the 3 tiers, it's so exciting, and I know how much work you all did putting that together, and it's just been a fantastic project. So thank you for sharing your information with us and insights, and I just want to open up the conversation. If folks on the line have questions, feel free to unmute your line and just ask Kim and Betsy directly, or you're welcome to use the chat box that's on the right-hand side of your screen. I am glad you snuck in a picture of the cultural trail, Betsy. I think that I was just in Indianapolis the other week, and I did try out the new bike share, or it was new to me anyway, and rode on the cultural trail, and it's just a wonderful place to bike ride, nice and flat. And a beautiful city, I have to say. Whenever you talk about the size of Indianapolis, I reappreciate the expanse of the project. 400 square miles is quite an undertaking. So I know the very last challenge that you mentioned was about the limitations of data, and that's certainly come up with other coalitions and other projects, really kind of thinking about how do you get beyond the county level data, how do you kind of really drill down into what's happening in the community. And certainly walk audits are a great strategy, not only to engage community members, but to really kind of get truth, I guess truth telling, or kind of ground truthing what's actually happening on the sidewalks and how folks are feeling about their places. Do you have any other reflections or any comments about the limitations of data that might be helpful for other folks to think about or to consider?
Sure. This is Kim. I'll jump in there. So really the biggest place that came into play was with regard to the health data. And if you can recall from that map of the health information, we were using what are called health planning areas, which are a standard, as I understand it, that are used nationally, but they're much bigger areas than, say, obviously a census block group or that kind of thing. And so when you look at the information at that scale, if you will, you know inherently that there are differences within, and it's pretty clear to see, and thanks for going back to that map, sort of the blocks that exist. And so you know there are differences within that block itself, but you're unable to get down into that and understand it better. The other thing was with regard to self-reported data. So our health department had recently completed a community health assessment and had done a very well designed and statistically significant phone survey to get information. But when we then started looking at like people's self-report of how close they are to grocery stores or how close they live to a park, that kind of thing, what we realized is how again, really wrong that information was, which is because people don't necessarily have a good sense of that. And when you think about miles or even minutes, that kind of thing. And so specifically for the access to parks and greenways, we had started using the self-reported data and ended up switching to a model that used the GIS data, where we actually then drew buffers around the parks and greenways in order to quantify the number of people that had access within, say, 10 minutes or a half mile, whatever it was, because that self-report data was very clearly unreliable.
Interesting. Thanks for that.
So I guess, sorry.
Oh no, I just was going to say I think a lot of folks have experienced that.
Yeah, sure.
I like the adjustment using of course GIS and buffers. I think that's a smart idea, though not everything can be adjusted quite like that, unfortunately.
That's exactly where I was headed myself. Yeah. So where you have the ability to adjust and be flexible in what data source you use, that's great. Very rarely is that the case. And so part of the work is learning what those disparities are, because we can be certain that the next time the health department does their survey, they will be asking questions a different way as a result, right? So you continually learn even when you're when it's difficult.
Well, and I was just chatting with a coalition from Cohort 2 yesterday, and it's in a rural county in Oregon, and they're going through a community needs and readiness assessment. And their consultants were talking about different apps like Map My Run and other things like that they're actually pulling data from apps and creating heat maps to show where people are typically going and kind of the routes people are taking when they're walking or running, which I hadn't considered. But I think is an interesting source of data and kind of gets at a little more of the objective routes instead of people saying, well, I ran 3 miles down this path. In fact, you can actually see, where folks are going and what's the most popular way to get there. All this data, they're tracking us all the time. Pretty soon we'll know everything about ourselves. Well, we're just about at 12. Had any questions they wanted to ask Kim and Betsy while we have them on the line? And I'll go ahead and chat my email address. You're always welcome to contact me, and I will forward along any of your concerns or questions. And again, it was just such an impressive project, and getting the master pedestrian plan developed and then approved is really exciting, and it's also exciting to hear that the Go Gorilla campaign is continuing and other ways to kind of promote the work and really build on the momentum that was started through Plan4Health and, of course, all of the work that Health by Design has been doing for many years.
Thank
I
you.
will officially...
No, go ahead.
I'm just going to officially close our call. And thank you again, Kim and Betsy, for being on the line and for sharing your project. And we will post a recording of the peer call on the Plan4Health website. And certainly if you do want to take a deeper dive into any of the documents and really look through the maps and the prioritization process, I would highly recommend Indy Walkways. It's a great website, and there's lots of info there.
Thank you for having us.
Thank you. Have a good afternoon.
Thank you. Bye-bye.
Bye-bye.
Bye.
The leader has disconnected. The conference will be terminated in 5.